our mission at ConsenSys Health, and particularly why making the patient-centered data accessibility and verifiability problems a reality with a solution we consider the health utility grid here at ConsenSys Health. Now, a little bit about myself, Mike McCoy. I'm based in Philadelphia, Pennsylvania, and I was born in Florida, but I grew up in the Philadelphia suburbs most of my life. And actually, fun fact, Christine's from Philadelphia as well, kind of how we had a mutual connection with each other. She grew up in a neighborhood called East Falls, which is near where I was from as well. So glad that some Philly connections can be brought across down to the Southeast. I'm, as she mentioned, the Director of Platform Integration and Technical Partnerships at ConsenSys Health. I also am an adjunct professor at a university hospital here in Philadelphia called Thomas Jefferson University. And I'm also the chair of the Linux Foundation Hyperledger Healthcare Special Interest Group. This is a working group. The special interest group is more of a let's educate the world on blockchain healthcare. And we have 4 different subgroups within the special interest group that help work in payer solutions, patient solutions, as interoperability solutions within healthcare, along with use case development of how to use this emerging technology in industry as well. Now, for my presentation today, I'd like to cover 1, an introduction to myself, 2, why I believe health data is truly valuable, 3, about our offerings at ConsenSys Health within the health utility grid and elevated compute, as well as a technology overview, because a lot of the terms I will use are much on the emerging side, and particularly in the emerging software and somewhat hardware angles. And I'd love to kind of have a more open forum conversation about those details. Then, of course, have a Q&A as well. And if there's any point in my presentation where you're confused or it doesn't make sense, feel free to holler. Feel free to, send something in the chat, and I'll try and get to it as quick as possible. I want it to be an open dialogue so you don't lose your thoughts or your questions. About myself. Awesome. There might be some background for me. My girlfriend and I live in a 650 square foot apartment in Philadelphia. So if you hear dinner cook in the background, that is not me. It's just that's in my mic. Sorry. If y'all love some pasta and meatballs, let's go. Anyway, a little bit about myself. I actually got into technology a little bit differently. I did not study computer science or IT in any shape or form when I was in college. I actually went to school to study broadcast journalism, particularly to be a sports reporter. And I was very lucky to be able to have access to become an intern at places like ESPN. At the time, it was called Comcast Sportsnet, and to work in video production for the Philadelphia Eagles. That at one point I got a job speaking about sports on TV for ABC 13 in Houston, Texas, where I primarily covered Texas A&M high school sports as well as pro sports around the Houston area. So I was kind of unconventional going into technology. But from around 2006 until even when I was working in TV, I was working as a medical billing assistant, or more like associate, at a health system in the Philadelphia suburbs called Mainline Health. And at that point, even in 2006 until I believe it was 2015, I was still working there. The system of being able to track and record payments was so disparate. And then identifying who actually had those claims to payment was all over the place in one-to-one systems, sometimes not even spreadsheets, going on paper. It was just a whole mess. And so my introduction to healthcare technology and systems was very much in a Stone Age type of scenario. And it kind of what caught me and kept me interested into the field. I came back to Philadelphia in 2014, 2015, and wanted to get more into technology because a lot of my peers in college were into it, and I just felt it was something I really wanted to be more passionate about. So at first I got in through working as a technical recruiter. Then I became an autodidact and learned and took online courses on Coursera and on different platforms. And then I also happened to just meet other people who taught me how to program and code. And so my journey of learning technology on my own, going to very high technical meetups in the Philadelphia area, and going to meetups like this one as well, helped educate me and understand how software, hardware, DevOps engineering large cloud computing could actually work. And so that's a little bit about myself and how I got into this whole mess. I actually joined ConsenSys, the parent company of ConsenSys Health, in 2016, 2017, and I was working in a role of ecosystem development. I've always been in the mode of product ownership, product management, technical strategy. And so though I know how to program code, I don't do it on a day-to-day basis. I can be able to talk about the different systems and the different tools and functions we use, but I will not be giving a technical demo today of what we were able to present. So, but I can answer those detailed questions if you have any specific technical ones as well. All right, next on. So to frame how and why we've created what we are at ConsenSys Health, as I mentioned earlier, we started as a full startup out of ConsenSys AG back on March 2nd of this past year in 2020. And before you know it, a global crisis hit us and a national and global pandemic took over our lives. Right now is a huge turning point, or could be a breaking point for technology in many ways. For one, the COVID-19 crisis has exposed a lot of the vulnerabilities, not only that I saw in our health system from 2006 to 2015, but even today in our huge technical or digital revolution, whatever you want to call it, there are many one-to-one systems that cannot talk to each other. There's forces between whether you're going into private industry and receiving private care or public care. There's a lack of global health standards across the board in uniformity, so we can be able to understand information together, not only within our own region of our state, but sometimes even in our own counties, between our own health plans, and even internationally, of course, and those problems are very well documented. And there's also a lack of resilience and collaboration between many health system partners, because in our, as we call it, our Web 2.0 world, you build systems and data and information, and the more data information you have individually, the more profitable you are. And there's a lack of incentives to be able to share that information. Whereas technology-wise, we're finally at a peak where we're ready to be able to shift and be able to interoperate certain systems, thanks to aspects of distributed computing, decentralized cryptography that can protect across different database server and virtual machine silos, as well as artificial intelligence and machine learning having reached a point of maturity so they can be able to analyze and predict trends at scale. And what I mean at scale, through large batches of data information. At first, we evolved and called the term big data. I hate saying that term, and I don't think it's relevant. We are using terabytes and terabytes of data and analyzing them at a pace that has never been seen before. And so from there, that gives us the ability to use our mini computers, our mobile computers, our mobile phones, as you want to call them, to be able to reflect and intake and ingest information like we never had before as well. But in there, in order to improve healthcare and life science in particular, it takes more than just being able to compute and ingest and digest all this information. You have to be able to give and grant access. And a person's overall health isn't just measured within the hospital walls, within your physician. It's measured in your environment. It's measured in how much you can afford healthcare. It's measured in your region at home, your blocks, the people you interact with most, etc. And a lot of that should be measured, but needs to maintain its privacy. For one, there's huge economic stability issues. As we are becoming a society that has more money going to the rich and more wealthy, a lot of those resources are not trickling down the way we had hoped. There's huge amounts of poverty, especially here in Philadelphia. I know there's issues just like that in Memphis as well. There's issues towards food security, scarcity, understanding the origin of where food and how it comes from, and then employing health care and public service individuals who are maintaining our health out in the world today, and being able to reimburse them properly for the great work they are doing. There's also educational problems with helping everyone in our communities to understand digital literacy, how to use an application, how to use a mobile phone, how to use a desktop or a laptop even, and getting access to own a laptop or having a laptop. Then there's the broader issues we are aware of within healthcare, such as health insurance coverage, being able to access and know what plans are covering you, going through and reading even just the the pamphlets you're getting in emails now that show the details of what you're actually covered for, and knowing and making that more accessible for everyone to kind of understand. I already mentioned the neighborhood problems, and then your community, the community participation, especially now with COVID-19 and being in more remote and maybe rural circumstances. People are going to be moving away from cities, and their communities are going to be affecting them even more so today, now that you'll be able to either trust or untrust the new communities you will be a part of. And so having bases of technology to help understand and help give you more comfort in who and how you're interacting with people is ever more vital as well. And plus, there's also a statistic of data associated to one person is so valuable today. What I mean by that, there's two things. And everyone talks about how blockchain is very valuable for financial services, right? Because one, cryptocurrency came out with Bitcoin, and when Bitcoin started, it was able to democratize access to money and finances. I think this same type of technology can democratize access and ability to show consent and management of healthcare data. Those two aspects, finances and our money, and the data and information associated to our bodies, is very much at high levels of value for all of us. And by what I mean by that is, we don't want to compromise by having everyone access the type of information, but we also want to be able to utilize that information so that we could benefit from it in some type of way, whether that's monetarily, whether that's socially, whether that is helping for research and science. There's a lot of ways we can be able to benefit that for as a whole. And as I mentioned, as data is growing, it's reaching a logistical and ethical and cybersecurity boundaries like never before. You can see here on this graph that per someone's lifetime, there's going to be 11,000 terabytes of data associated to their behavior, their socioeconomic status, their environments, and a lot of times that is controlled by a physician. It is not controlled by the person themselves. It is controlled by a third party of some kind. And that has always been the mantra and the system that we've had today. Someone else is recording our biological history, our genomic history, and we may not ever have control of that at some points of the process. Our genomics data is also going to become 30% of that. And then the clinical data, whenever we go into a hospital, when we're part of health systems, that data is being recorded as well. But it's really the behavioral data that people are starting to try and put a label on and put a semantic representation to. And that is becoming ever so important. I know personally for myself, I guess a little bit of a personal story. It's kind of funny. I actually found out I have two half sisters thanks to the service of 23andMe, right? They connected in with my uncle, and long story short, I found out I had family due to this new type of technology, right? And being able to connect and access and democratize healthcare information. Though I never even signed up for the service, because one, I don't believe 23andMe really takes much care of my digital rights and would actually grant me or make me aware of how and why they're selling my genomic data, and if they're selling that to insurance companies to raise my claims potentially, right? Those cases are far and few between. But there are many stories how democratizing this information of yourself and your DNA and your genomes is highly valuable and highly can create great stories in connection to human life. But there's also stories of how people can take advantage of it and put it into the wrong hands. And that's why healthcare data is so valuable and must be something we maybe not take control of, but have access and grant consent and ownership to more so in our lives. So at ConsenSys Health, we believe that we need a foundational compute infrastructure. And part of that infrastructure we call the health utility grid. Just as useful as water is and as necessary as water is to our everyday lives, we believe healthcare is going to be necessary to our everyday lives as well. And so in creating something called the health utility grid, we are creating the pipes, we are creating the infrastructure so we could take that information of healthcare data from data lakes and create the infrastructure and pipes to fuel into people in their homes. And by their homes, it could be their mobile applications. It could be their desktops and servers, and it could be into their physicians as well. We believe we can create a patient-centered way, and by patient-centered, it's patients having the access and granting consent to that information, and then being able to either be reimbursed for it at some point, or being able to just be knowledgeable of how and why that data is being used across many research institutes and many clinical institutes as well. But there are different sources of that data we have to be aware about. There's the health source data that we're getting and attributing to wearables, Internet of Medical Things devices. And these wearables are something like our Fitbits, they're our phones. They are even now, I used to work on a project with Comcast, a cable company here in Philadelphia that is partnered with Independence Blue Cross Blue Shield, the medical insurance company, and other research institutes, that they're even starting to create sensors on our set-top boxes, in our TVs, in our homes, that are going to be able to monitor and surveil ourselves in healthcare data. So sensor tech combining into healthcare data, combining into these AI and predictive softwares are ever more prevalent. Then there's derived data, as I mentioned now, of the data that's coming from ourselves and wearables. There's the health source data that comes from EHRs, EMRs, electronic medical records, electronic health records, that a third party, mostly a physician-led party, will be able to create, ingest, and analyze over time for you to be able to use on. And then there's the health transactions themselves. Being able to know how and when the data is going between different silos and between different parties is incrementally vital, because when you know how and why data is being used and information is being used that's attributed to you, you can then infer better trends over time. And we have a way to maintain the privacy of those transactions, of the derived health data, and of the source data where it's originally stated at. Any questions so far?
I don't think there's any questions. There were a few questions in the list. I think we can wait till the end. It was more about what.
Yeah, I'll get to those at the end.
Okay.
But yeah, awesome. Thanks, guys. So from this, we need global change. We need, as our founder, Heather Flannery calls it, a radical model. And I don't believe in radicality or being radical per se. I believe in creating value for people today. But in creating these global frameworks, we need a new class utility, and that's implemented both on the private and public sector. Because for one, today in our public sector, within our federal government and maybe our state institutions, they're not driven by profit creation. They're actually driven by getting it right. They're focused on building the infrastructure and making sure they have the amount of resources and that their federal dollars and their federal spend is going in the right ways. And so they'll take more time to make a decision. Or in the private sector, they're very much profit and value driven. They're incentivized to create a closed system that may not be able to share well, or a system that may not be able to be accessed well by other people because they have highly valuable information. But they also work in a rapid and agile way. So they are constantly iterating on that solution and value and making it as valuable and as necessary for the parties together. That's where our health utility grid global framework will be able to enable profit and won't be profit driven. We will help do it the right way, but also in an agile and rapid iterative approach. In doing this, we are creating those rails so that we reduce costs by having a blockchain and a distributed computing system that's protected by cryptography, so only valuable information that can and needs to be sent to both private and public sectors needs to be sent through those intermediaries. And we use aspects of smart contracts and automatic. So before I say smart contracts, I don't believe contracts are smart nor contracts. They're really just automatic transactional script in code. And through that automatic transactional script in code, we are able then we're able to automate aspects of yes or no send of information. For anything that's gray, in between those yes or no decision trees of whether you can send information to or not, that's where you need a clearinghouse or a third party or a data analyst to be able to help solve those questions together. But then you also want to generate new economic value for customers and consumers in these in these more remote social and mobile edge ways and cases, so that everyone has an access to input information and democratize the ability to access and add into health information for themselves. But then there's problems with that too, because there's potentially people that want to take advantage of that system. I would want to have more financial gain by adding in information that may not be true to themselves. So there's a lot of open issues with it. In doing so, here are the core concepts of the health utility grid. We want to be able to have municipal or community scale funded by public-private partnerships. And in there, we have very specific contracts that are able to allow the public entity to be able to access specific information that is consented and granted by the patient-mediated creator of that data. We then also have organized and governed health data as a new class utility. So health data will become a new utility that may have to be regulated in some states and some concepts, but then also will have the ability to be spread across others as well. Each utility grid will have a distinct legal entity. There's different laws and rules we have to abide by here in the United States, but then there's also socialized medicine in Germany. There's different aspects of utilitarian medicine out in the East as well. And so we are happy to create a grid that meets to all those different standards. We also will bring in contracts with standards compliant utility operators. So just like in the Industrial Revolution, we had creators of industry, and then we had industry laborers. We had people that were working in steel mills. We had people that were working in refineries to build up industry and physical products. We believe we will help navigate data laborers that will be part of the health utility grid. And by those laborers, I mean data analysts, people that are able to connect into HL7 fire messaging and different EDI messagings that can be able to help create this network of seamless interaction of information and data. And though the workers and the laborers will look different from wearing a hard hat to wearing a standing desk, it's a different method, and it's a different network of people that will still be building up this framework, and will create lots of jobs doing it. Yes, they'll have to be a little bit more computationally savvy and technically savvy, but it'll be a huge benefit to industry and to public institutions to fund people who may be looking for a new career. There's also going to be alternative capital formations when we're bridging those digital divides for mobile devices, and also for aspects, like I mentioned, of set-top boxes and TVs. Right? They're going to have different rules. It's going to be globally verifiable, self-attested identity. And by self-attested, this is a very tough problem. Right? And I'm lucky to be part of a lot of working groups within the W3C, the World Wide Web Consortium, the Decentralized Identity Foundation, as well as the Decentralized ID, the DID Foundation as well. There's a lot of digital identity working groups. And actually, I even read a study today that claimed that there was going to be more digital identity application companies than there will be physical card holders by 2023. I think it was Gartner came out with a study like that. And I absolutely see that. The digital identity problem is huge, and it's a money driver right now for a lot of people. But there is a specific way that we at ConsenSys Health have been able to orchestrate where you could take your traditional credential in Web 2 by using a username and a password, and using that unique identifier to then connect into a Web 3 architecture. And by Web 3, I mean a blockchain application or a decentralized app or a DApp. And we have created an architecture and a scope where you can be able to seamlessly connect into that and still have a unique identifier, and the ability for you to hold a private key if you would like to, or to grant access to another institution to hold that, but you will have to pay a small fee for that hold of it. That's really the only ways we'd be able to do it at this moment. But we also have aspects of verifying antigen and antibody tests as well, something I can go over later on in the process as well in the presentation. But we also want to be able the ability to conduct monetizable consents for data aggregation and exchange and use, and that's going to take not constant, but iterative approaches, as well as a lot of input from users on how and why they would want to even grant consent all these access points to continually share healthcare information. And at what points is healthcare information going to be too compromisable? And at what points is it going to be very needed? So those are things we really have to solve when we want to create a utility network to make that mission and promise valuable. But this is going to be tested, and we want to help with the education gap of getting those who may not be technically savvy or have the ability to afford and pay for a laptop or mobile device. We want them to be rights, American and individual rights, maybe not American, sorry. We want those to be individual rights to have access to these digital platforms, whether they are granted these devices at a cheap cost and rate, so that the data that is taken from those individuals can be solely very valuable to pay for the cost so that everyone can access the information. I'd love to talk about those specific details later on in the presentation as well. But in order to do so, you need to have the right standards bodies to be able to help with the regulatory composure and composition of how to do this. And not to be on our high horse, but luckily we at ConsenSys Health are part of the Linux Foundation Hyperledger working groups that are working on standards for this. We are running the Enterprise Ethereum Alliance working groups in identity and healthcare as well. We also run a lot of groups within HIMSS, within IEEE as well. We are also the creators of the technical standard for interoperability and blockchain technology within IEEE SA, as well as the business standards of them as well. Here's all the different standards working groups and the compliance we need to make this happen. And that's a group effort, right? That's not just us being the only people manning that. We have very open conversations with folks in these working groups, and we don't have a technical agenda. We just want the agenda to make sure that we are knowledgeable of it and that we all can work together within these specific platforms. And whether that's using Ethereum-based products or that's using Hyperledger, whether it's Corda, those are specific DLTs. But it's also being democratized as to whether we're holding all our information on Amazon Web Services and in cloud storage, or if it's on Azure. It's on Oracle. There's a lot of questions that actually need to be addressed, but you need to make all those different tools interoperable. You need to make, in an overall technical stack, all the different ways to hold cloud storage, to be able to use transactional technology like distributed ledger technology available, and how you could be able to input and output all those within a stack is highly valuable too. And that's something I was able to create while I was at Accenture prior to coming to ConsenSys Health. I helped create an open source item called Hyperledger Cactus, and privately there's a technology called Blockchain Automation Framework that helps you keep your data state and go between other DLTs, but that's something for another conversation. At ConsenSys Health, we have a platform that helps you take your state of data information and also use different DLTs and different storage mechanisms to help spread out and democratize that access as well. And those are things we are constantly having diligent and educated discussions within our IEEE and other regulatory framework and working groups. Any questions there?
Yeah, it's okay to talk.
Yes.
I'm fundamentally confused about the hug.
Why?
Because what you're talking about here is the text of things, and I can see that, and that makes you a tech company, and that's fine. But I heard Heather about this speak about those same slides as well. What I understood is the hug is bigger than just its provision of a tech service and platform. Like, I think you were saying as well, accessibility. So how do you get people to actually have a mobile phone and a laptop? And I don't see, like, do you see, or does ConsenSys Health see this as part of the job? Are you involved in that?
We directly may not be involved. Yeah, that's a good question. We may not directly be involved with connecting with those in different communities that need these digital on-ramps, but we are going to partner with institutions that connect into people with third world countries and vulnerable populations in the United States and around, that to help them, educate them, and tell them the value add and the value drivers, and connect with those even homeless shelters, right? For one, I ran a pilot this past year in Philadelphia of helping people who were digitally misinformed within a place called Project Home, which is a homeless shelter, of how to be able to use different mobile applications. And that's in my local community, but we're going to partner with others in these many different communities, because the only way to access and get people interested in this type of platform or technology is if they understand and they feel comfortable with it. We are not going to probably be the direct drivers of it, but we will connect with partners who are. Cool. I will continue on. Thank you for the question. Now, this is ConsenSys Health, our elevated compute platform, is powered by a matching engine of a lot of different technologies. For one, we are able to connect into payer data. You could bring in AEHR data, put personal and mobile user data, information that's connected into your employers, as well as Medicare and Medicaid data all in one. In our elevated compute platform, there's an analytics and learning models into there where you can be able to, for one, find hotspot tracking for COVID-19 in a viewpoint here, as well as be able to pinpoint mental health resource centers, as well as be able to input and track your own mental health issues. Those type of applications are going to be released in April of 2021 as they are, as we're building our whole infrastructure together. But within that, we are going to be able to combine multiple and infinite data sources together, accessed in one place, and then you'll be able to have fully identifiable and clinically relevant source data all together. And from the individual view, you will have the ability to match your services, to be able to have insights and intelligence based on your insights, and even some incentive mechanisms, whether they're monetary, whether they're socially relevant, where you can be able to interact and connect with multiple different people as well. We have many different abilities to be able to connect in these type of avenues. For one, we have patient-centered applications. So for healthcare users, you're able to use out-of-the-box applications in April of 2021. A patient-facing application where you can be able to have a self-sovereign identity, interact with different wellness programs, donate to charities, find resource matching into care situations, and even resources into overall wellness. We also have the ability that you could be able to record your simulate your health record and predict over time with your habits today how they may improve or not improve your future state, as well as to simplify your payment mechanisms. And then we also are helping with enterprise applications for employers or for even public-facing organizations that they want to connect their employees to. There's many different ways with those same type of incentives, but also real-time layered benefits adjudication as well, and data and payment claims adjudication, so that everyone can be able to benefit from all this different technology too. And the main story of all this comes from the new semantics of data. So for one, there's enterprise data behind firewalls. They're at rest. They're never moving at current state. And there's patient self-sovereign data. That's in cloud storage infrastructures that are going to be held on edge devices. We have a mechanism using a technology called federated learning, as we call it, that helps us to be able to maintain a message beyond the firewall at rest that's not de-identified, but doesn't carry the information that's associated with patient health information. And we are able to create learning models on one-to-one basis across a network to identify and infer trends, especially for things like highly critical diseases, tumors, cancer cells, etc., that we are able to utilize within this network. And we also hope to be able to create federated learning networks to derive social determinant health data as well. And those will be verified and tested by health professionals, down the road. We see a paradigm shift in value creation. The sunsetting paradigm is where right now we just copy and move data. We create many different spreadsheets and CSV files and Excel spreadsheets. And a lot of times we just de-identify it. And sometimes companies and health systems pay hundreds of thousands of dollars to just send over a different Excel spreadsheet so that the clinical data makes sense. Clinical data is complicated and is not an easy transition. But we believe we should include the provenance of that information, being able to keep it where it's originally settled, whether it's in a patient's mobile phone, whether it's in enterprise's original spreadsheet or CSV file, and to be able to extract that into a learning model unlike ever before. And we're doing this in that federated learning network, as I mentioned. Now, here's some technology that is a part of that, that is a little bit complicated. So if anyone wants to discuss this type of paradigm in particular, before I get into how these emerging technologies kind of come together, I'd love to review. If anyone wants to call, besides the chat questions, yeah, if you want to bring it up.
How are you going to handle massive data pools from an enterprise-based source if you're pulling in multiple endpoints into your federated model? How are you checking that? Because, I mean, if you've got something that's coming from multiple EMR systems, you know, one's coming from Cerner, one's coming from Epic, one's coming from a home-built application, you know, that a rural community is using off an old SQL DBase, how are you going to be able to break all that up into data ownerships?
Absolutely. So at rest, we will then be able to, within our system, verifiably compute. Have you ever heard of a technology called trusted execution environments or secure graphical exchanges?
I know what secure graphical exchanges are, but I mean, that's going to deal with your certifications and how your certs are going to be done through your cryptological based key. But, you know, that is on a one-to-one basis, not in mass. That's only by individual.
We're going to, so luckily we're connected with partners like Intel and others that are creating those type of SGX machineries that can hold certifications at mass rather than in small scale. And that's part of our secret sauce and how to be able to do that. We also will be able to have regional aspects and have regional credentials that then can be inferred onto national cloud-based infrastructures. And by doing that, we are connecting into SecP256 elliptic curves and being able to associate if someone is matching into the key that has been appropriated via coming into the ConsenSys Health elevated compute platform. So at first, it's going to be an iterative approaches regionally, but then as we are building, we are going to we hope to have a data semantic logical language all together so that those data points can be able to talk to each other more efficiently.
Well, the reason why I say that is because if you have to do, like, say, a company that deals with high trust, for example, you know, your cryptological key must be more than 256-bit encryption. You know, and if you're talking over 100,000 keys, let's say, you know, that are based on medical records, and you're going to ingest those at a data rate and from a data pool, how are you going to be able to aggregate, saying, okay, that's going to go to cancer, that's going to go to lymphoma, that's going to go to COVID, that's going to go to, I mean, how are you going to separate those lanes? Because those swim lanes have to be set up, you know, individually. You can't do them in mass.
They are going to be set up individually. We're going to label and credential them at their existing point. And in doing this too, we are going to create an architecture and a data semantic format where each ingest and each time that data is being inserted into the model is going to have specific criteria it has to match. And in that criteria, we're going to have an automated criteria matching tool via transactional script of smart contracts, if you want to call them, so that information will funnel into specific lakes, if you want to call them data lakes. They're really just connecting to virtual machines that will be organized and then funnel into regional systems.
And this isn't able to happen now. I mean, this is, you guys are working on the backbone and all the semantics, and there's many groups that are working on how to have the interoperability piece work. I mean, it's not going to be happening tomorrow.
Yeah. So right now we're doing it on chest X-rays, and we're able to actually create federated networks on chest X-rays and specific medical imaging analyses. but it's not at a high level yet until the specific software that Intel is going to be releasing for us will be released in April of next year. Then we can do it at a larger scale. And we do believe at some point there will be a limit where you can only be able to create federated networks regionally, then create into a mass scale to create secure inference from those federated networks into a larger pool and aggregation. But yeah, that's currently what we're able to create learning models on today. A little bit, especially when you're using more aspects of cryptography to protect the message. So for one, we also have an ability to use differential privacy. Differential privacy is able to just create cryptographic noise on a message, but then as you add more cryptographic noise, you lose the accuracy. So there will be some fidelity loss when you're going into a larger, broader scope of analyzing data information automatically. But in those cases, our utility grids will then, that's going to have a problem and a challenge we have some hunches how we're going to solve, but it's not a guarantee either. So it's a very good question. Yep. Awesome. So I would get into some technologies and why they're very pertinent to what we are doing here at ConsenSys Health. Sorry, I can't see any of the chat questions, so I just have my presentation screen on. So on the left here, you can see a lot of components that are relevant to specific blockchain technology. And then on the right, here's some added value technology we are creating in-house as products that will go on top of the ConsenSys Health elevated compute platform. Those are decentralized apps, tokenized assets, smart contract, as I mentioned, automatic transactional scripts, and then there's the blockchain DLT lighters themselves. But then what we are able to create at ConsenSys Health is privacy in depth and decentralized AI. And I'm sure you all are pretty familiar with zero knowledge proofs. What they're able to do is they're able to prove within a server or a network that someone has a data point without actually revealing any of the details associated to that data point. We mentioned trusted execution environments already. We also have aspects of verifiable computation. So from a geolocation or from an IP or a computational address standpoint, you could be able to verify and validate, not to 100% certainty, but to high levels of certainty, how and why, where a data point is actually coming from. And then there's aspects of secure multi-party computation, which include homomorphic encryption as a word. What that really is how to put homomorphic encryption simply, it's being able to cryptographically secure messages without knowing the underlying details of them between a network of participants as well. I mentioned just differential privacy, and then we are exploring very much in R&D state aspects of quantum resistance encryption. I am definitely not an expert in this, though I believe reverse cryptography and aspects of reverse quantum cryptographic methods are possible. I'm not the biggest expert on that, so I won't be able to talk any details to it. We are, though, creating aspects of decentralized AI, and that is federated learning in blockchain-based networks. And we're able to do this in many different languages, though we are traditionally using aspects of Terraform or TensorFlow, specifically using also PySift and PyTorch as well to create these networks. We are big fans of open source software communities to create decentralized AI rather than maybe the C++ communities, but we're still able to do so. We also are creating intelligent agent-based automation through chatbot features or through voice-enabled chat tools, and being able to, when someone inserts text or ciphertext or plain text, sorry, not ciphertext, plain text into the information, we use ciphertext to then protect that message to send out as responses to care over time. We also want to have better learning methods to those agent-based simulations, and then we want to create a new paradigm shift into how data is being provenced and being governed over time. And those are more exploratory phases, but those are things we're diligently working on with our team here at ConsenSys Health. Any question on some of those technological advancements? Absolutely. So within machine learning, right? A machine learning model just takes in an input and then learns of the different mathematics you're teaching it to then give you an output of that desired outcome. So if, for instance, I'm going to the hospital, let's just say they're trying to just take in times that someone's going into hospital. If I'm going in usually, and I'm coming for healthcare on a daily basis, I'm going in at 8 o'clock, 8 o'clock, 8:05, 8:05, 8 o'clock. The machine learning model over time will take my inputs and then create an average output of that I'm coming in at 8:03, right? In this machine learning model, let's just use time as the example still. You're able to create, and let's use this graph as an example too. So let's just say the machine learning model is coming from here in this database and server of my records coming into hospital A, and this is hospital B, and this is hospital C. I'm able to create a learning model of my time efficiency for hospital A, but I don't want all the other hospitals to be able to see that information because it could compromise the way the hospital may advertise to me, the way they may have their hours of operation. They may only be open for certain hours for people of my type of care facility, etc. And it could just be compromising information, but more compromising information would be the details associated to me so they could potentially advertise to me, or they could potentially have, they could open up specific care facilities to compete against the other hospital, etc., etc. But I want to be able to hold that information with me, but still be able to share the insights together. So what this does is you create a learning model between A, B, and C. The learning and the algorithms stay within the hospitals, behind the firewalls, within their institutions, so it's never shared. You're able to then share the insights and the results of your output of information in your learning model into the trusted execution environment. And here we have the example of Intel SGX. And all their insights are being reported to the XGX. Then those results of output are then sent to a blockchain distributed network so that anyone that actually wants and is able, has access to see those insights, can be able to do so. But also at the same time, the people that were associated to the learning model, the patient health information that is associated to creating that information is left anonymized and unidentified and not taken into the model to be then sent out to everyone else. So that's how I mean by if a public institution or the person who created the federated learning model needed to verify all those identities, they could be able to go into a different audit trail and be able to access from the keys to then go and understand if that information is truly relevant and to help with, to be audit compliant. That's why it's fully identifiable as we stay here. And then we also say it's clinically relevant because you're staying HIPAA and GDPR compliant because you're not holding and taking advantage of any patient access and information. And people always say, okay, well then you could just reverse engineer those findings to be able to find out who the person is over time. But since you're only able to reverse engineer the insights and the output given, the engineering and the learning model has stayed here in the SGX. Unless you have access to the SGX, which most people who are part of this blockchain network will not be able to access every single SGX, then the source data is never revealed or shared. So I hope that's a deep, detailed model of how we're using privacy-preserving technology for this. Absolutely. Absolutely. 100%. Any other questions on that concept or model? Thanks, Ken. All right, I'll move on. I guess that's the end of my presentation. So, hold on, go back. So that's pretty much the message I want to get across about the technology and how it's actually used. So we can go into Q&A after. I'll give a little plug to some events that are coming out that are very meaningful to us at ConsenSys Health and why we're doing this. So for one, I mentioned I'm in charge of the Hyperledger Healthcare Special Interest Group. I would love all the people in this working group to help work with me and work with the different teams I'm associated with. And within our special interest group, we get together every other Wednesday at 10 a.m. I forgot to put that on here. At 10 a.m. on Wednesdays. So if you want to be part of our mailing list, you want to be part of our network, I actually emailed Christine the link to join the Hyperledger Special Interest Group. And that's a specific link if you want to all take screenshots, or I might just add it into the chat as well. But more locally,
I'll send out an email to everyone with all this information too, so it'll be easy to click on it for you.
Let's go. Awesome. There's also a cool event coming up on Wednesday after the election. So I know we're all going to be tired on Tuesday, having to get up, vote, come back, do our work, which is, yeah, it's actually a pain. We should just be able to do it on our mobile phones, but hey, I'm not the president. So we do have an event within IEEE. It's called the AI and Blockchain Industry Day. It's part of a virtual series. That's going to be starting on Wednesday at 9 a.m. next week. We have presenters from MITRE, from Chronicled and the MetaLedger Project, from Mayo Clinic, from IEEE itself working on some of their demos and projects, along with blockchain AI specific to medical devices and how they're using sensor tech to ingest information properly and at scale. I highly suggest everyone join this presentation. It's a shameless plug for myself. I also want you all to join another IEEE event, which is going on Thursday on November 5th, which is the second international workshop on advances in artificial intelligence and blockchain. It's called AI Chain 2020. And that'll be happening Thursday, all day on Thursday. So you can go onto this link, aiforblockchain.github.io. We actually, ConsenSys Health, wrote a paper with Microsoft and with the universities, Thomas Jefferson University, which I'm a part of, and Imperial College of London, on how federated machine learning with advances in AI and medical imaging can be possible. It's a paper we released, but we have a workshop as well that day to display what we were able to put together in research. So I'd love for you all to join all three of these events and working groups because it's people like yourself that actually work in health systems and that are interested in blockchain technology that can really have a huge impact on us building these systems of relevance. And the health utility grid is a theoretical thing, right? It's something we're building and working towards, but it doesn't happen unless we have actual people that are a part of it. And unless we can create something that incentivizes you all to be a part of it and wants you to be a part of this network, it does not matter. So if all I'm saying here doesn't make sense or doesn't seem like a system you want to be a part of, let me know, because I want to build a system of relevance, of value, so that everyone can use. And that is my TED Talk. I'm open for Q&A. So thank you very much.